next speaker is currently a consultant rheumatologist and a lecturer at the University of Birmingham. She is credited with playing a pivotal role in the establishment of the first department of rheumatology in the Khyber Pakhtunkhwa province.
With numerous publications to her name, Dr. Tajvur is a well-renowned speaker at many national and international conferences. Kindly welcome Dr. Tajvur Sabir onto the stage.
Thank you very much for this invitation. Assalamu alaikum, everybody. So my talk is on an update on management of Sjogrens. I have a couple of disclosures. My talk is going to have these four relevant topics. So, first of all, talking about diagnosis, we do know that Sjogren's is the second most common autoimmune disorder and does actually carry a mortality, which previously used to be thought as a simple disease with dry eyes and dry mouth. But as we increase our understanding, we know that there is some mortality. The incidence is about half of that associated with rheumatoid arthritis. There seems to be environmental or other triggers that promote activation of the immune system and thus production of interferons. These then induce B-cell activating factor that have a key role in activating autoreactive B cells. If these remain continuously activated, they can cause deficiency in the control of NF-kappa B activation and can lead to lymphomas. Epithelial cells seem to have a major role in Sjogren's development. And while there are many similarities between lupus and Sjogren's, the key difference seems to be mucosa tropism, the cause of which is not yet fully understood. So key features, as we know, dry eyes, dry mouth, lymphomas, and skin diseases possible. There are usually extraglandular features present in 70%, and in about 15% these can be quite severe. So according to the American European Consensus Group, you have to have 4 out of 6 criteria, usually dry eyes, dry mouth, objective ocular dryness, either checked with Schirmer's or with a Biesterfeld score, objective oral dryness, checking with unstimulated salivary gland flow rate of less than 0.1 ml per minute, positive Rowan antibodies, and labial gland biopsies. When we do a labial gland biopsy, we usually look for a FLS, which is focal lymphocyte salidinitis, which means there are dense aggregates of mononuclear cells, mostly lymphocytes, in a periductal or perivascular localization. When we do a biopsy, we try to pick 4 or if small 6 little individual salivary glands. And we calculate the number of foci, germinal centers, or areas of leukocyte infiltration. For the eyes, fluorescein staining of the cornea or listamine staining of bulbar conjunctiva is done. And ultimately, an ocular staining score is calculated. We also calculate tear breakup time, which is done via slit lamp and adding a dye. If there is between 9 to 10 seconds, it is considered mild, 5 to 9 seconds moderate, and less than 5 seconds means severe disease. Ultrasound can help. When we do an ultrasound of the parotid or submandibular glands, we look for inhomogeneity and anechoic or hypoechoic areas which represent active disease. Looking at current treatments, I very highly recommend you look at this paper, which gives very useful short paragraphs with lots of recommendations. So, looking at the tear film, there are usually 3 layers. There is a top lipid layer created by the meibomian glands, an aqueous layer that nourishes, and a mucin layer which helps adhere tears to the eye. In mild disease, hyperamylose eye drops. In moderate, carmylose, and in severe, if the breakup time is less than 5 seconds, hyaluronate eye drops can help more. And these associated drops can be given. For example, cysteine is a polymer of boric acid, hydroxypropyl GOR, etc. I can provide you the names if you want to look for local brands. It's also useful to conserve the actual tears by warm compresses, which can enhance meibomian gland production. Wearing spectacles can reduce tear loss by up to 30%. There are also specially created moisture chamber spectacles. Humidifying the air in the room can help, and punctal plugs can help, but they need to be of the right size. If they're too big or too small, they cause further irritation, or they're not useful. A patient can be referred to an ophthalmologist for further specialist treatment. This is the kind of paragraph given in that article I mentioned. It gives very useful, lots and lots of details if you're running out and a patient has a particularly sticky problem. For dry mouth, there are lots of gels and sprays which we have used. They haven't been as good recently. Pilocarpine can be used starting with 5 milligrams up to 20 milligrams. Meticulous oral hygiene does seem to have a role. High fluoride toothpaste does seem to improve outcomes. Hydroxychloroquine, unfortunately, given at 400 milligrams for 12 months, did not have a worthwhile clinical benefit in dryness, fatigue, or pain, although it did improve the hypergammaglobulinemia, ESR, and IgM to an extent. Then secretagogues can be considered, or tear stimulants. Ribemapide is a local drug that I have learnt more about here in Pakistan. It is originally was used for gastritis and gastric ulcers, orally administered. It's trialed in India, and there seems to be experience in Asia that supports its clinical use. This can suppress IL-6, IL-17, and TNF, and in vivo even help significantly. It seems to result in fundamental improvement in symptoms of Sjogren's, and my colleagues in Pakistan tell me it is very useful. A Mediterranean diet can help to either prevent or reduce the amount of symptoms that a patient has with Sjogren's. Then the next topic is severe systemic manifestations, of which we're going to discuss 4. First of all, cryoglobulins that can develop. These are immunoglobulins that precipitate at less than 37 degrees and produce end organ damage, either through vascular sludging, which is a mechanism in type 1 cryoglobulins. These are mostly associated with hematological pathology. Or type 2 and 3, which are called mixed cryoglobulins. These cause principally vasculitis-like changes, and 90% are due to hepatitis C virus. Sjogren's comes under this category as well. Checking for cryoglobulins is quite difficult. I remember from when I was a junior doctor, we had to do it in a particular way. You have to have a thermos at 37 degrees. The test must be collected. The sample is carried within the hour to the lab, where the serum is separated and then incubated at 4 degrees for 3 to 7 days. If there's no precipitate, the test is negative. If there is a precipitate, it is resolubilized and rechecked. If the test is positive, you have a positive cryoglobulinemia, which occurs in 5 to 20% of patients in Sjogren's. Of these of the total 3 to 4% patients with Sjogren's can have cryoglobulinic vasculitis, which is quite a mouthful, so I'm going to be referring to it as CV. Cryoglobulinemia can cause problems in the skin, such as purpura. It can cause cutaneous ulcers and livido, which suggest medium vessel involvement, arthralgias, sensory and sensorimotor neuropathy, as well as membranoproliferative glomerulonephritis. Not all purpura in Sjogren's is due to cryoglobulins. In this Spanish study, 515 patients were studied. 12% had cryoglobulins. Of those, 32% developed CV. If the patient developed cryoglobulinemic vasculitis, those patients had higher type 2 cryoglobulins, higher cryocrit, and higher disease activity. Patients with primary Sjogren's who fulfilled criteria for cryoglobulinemic vasculitis at diagnosis, long-term follow-up showed that 6% of them died and 9% had lymphoma at the end of about 10 years, 9 to 10 years. In this RCT, 59 patients were studied and treated with rituximab, even if they had previously had HCV positivity, treated with antiviral therapy such as interferon and ribavirin. They had either failed, poorly tolerated, or it was contraindicated. Even those patients were treated. Patients who were given alternate treatment were given either glucocorticoids, azathioprine or cyclophosphamide, or plasmapheresis. Thank you very much. Thank you. There was actually quite an excellent response in those given rituximab in this study, and it was maintained, and when needed, follow-up rituximab was repeated and gave an excellent response as well. So long-standing treatment for life-threatening manifestations with CV includes plasma exchange if it's severe, hydrosteroids and rituximab. If there is leg ulcers, consider rituximab in local care. If there is local infection, obviously it needs to be treated. If we do give plasma exchange, it's important, if you have time, to try and give it at least 3 days prior to rituximab so it's not washed out. NMO spectrum disorders, neuromyelitis optica, means CNS inflammation, first described by Dievik in 1894 as a necrotizing inflammatory myelopathy of more than 3 segments of the cord associated with optic neuritis that can be recurrent, usually unilateral. There can be a pathogenic immunoglobulin autoantibody which targets aquaporin 4 water pump channel antigen in astrocytes. Sometimes NMO spectrum disorders can occur without actually having optic neuritis. IL-6 may be involved and have a role in severity. Sometimes the aquaporin antibody is negative, and in these, anti-MOG has been identified as a test. Pathology may be different. This is a case of a 73-year-old lady who presented with progressive weakness and numbness of her left leg and doubly incontinent for 2 days with a sensory level below T8 and reduced sensation to light touch and pinprick. Her MRI showed multiple levels of spinal cord inflammation and bilateral high attenuation in the brain. CSF protein was high at 0.7 grams, and oligoclonal bands were identified. Other causes were ruled out, such as HTLV1 and antiphospholipid antibodies were negative. She did fulfill clinical criteria for Sjogren's. Her Sherman's test was positive, Rho antibody was positive, and therefore she was treated with steroids and cyclophosphamide, followed by azathioprine. She made an excellent recovery. Therefore, treating for a neuromyelitis optica, usually starting with prednisolone, tapered orally over 2 to 6 months, and plasma exchange, which seems to be increasingly considered earlier on. Cyclophosphamide has been used. Other drugs are used, but there seems to be less effectiveness or less evidence for use of methotrexate. There are other recent clinical trials ongoing. The next complication is sensory ganglionopathy. So on the left side, you can see a picture of the dorsal root ganglion, which starts in the posterior column. So in the second order neurons, there are either large and heavily myelinated neurons, which end in the Pacinian corpuscle, which is an encapsulated sensory nerve ending for pressure and vibration, or small sensory nerves, which are either thinly myelinated or not myelinated. Usually T-cell infiltration of the perivascular mononuclear infiltrates lead to degeneration of the axon, And there can be multiple symptoms, as you can see in the column on the right side. The presentation shows that it's not necessarily length dependent, so it can present in the face and arms before presenting in the legs, which would otherwise have been the case. It can start in any territory innervated by sensory nerves, can be multifocal, so there can be a combination of proximal sensory symptoms, but usually strength is preserved and can be asymmetrical. In this 56-year-old lady with primary Sjogren's, she presented with paresthesia, tingling, burning, dysesthesia, with an inability to know where her hands were in the dark. She had reduced touch and vibration. Perception, she had decreased proprioception, and therefore pseudo-athetoid posturing, meaning she had writhing movements of her right hand when her eyes were closed. She had reduced tendon reflexes. Some of these patients can have autonomic dysfunction, such as orthostatic hypotension, arrhythmias, gastric dysmotility, and disturbed sweating. Usually motor strength will be preserved. There can be paraneoplastic syndromes and differential. Differential is very important, especially if there is raw antibody negativity. Then perhaps a biopsy should be considered, because this can occur in small cell, bronchial, breast cancer, ovarian, prostate cancer, as well as lymphoma, neuroendocrine tumors or sarcomas, various viruses such as HDLV, EBV, Zika virus, and enterovirus, etc. And these are the common conditions. Treatment for ganglionopathy is high-dose steroids, followed by IVIG, plasma exchange, rituximab. You'll notice that steroids, mycophenolate, cyclophosphamide, and hydroxychloroquine did give a response, whereas tacrolimus and azathioprine did not, if you look at the table. The sensory loss is usually early. Within the first 8 weeks, seems to be quite dramatic, quite early on. Interstitial lung disease is the next severe associated condition and can be of various types, such as NSIP, bronchiolitis, pneumonitis, lymphocytic interstitial pneumonia, organizing pneumonia, etc. Amyloid, although less common, is more associated with mortality. There is an increasing incidence over time, usually 10% ILD in the first year and up to 20% at the end of 5 years. There is an associated reduced survival with interstitial lung disease. There seems to be lots of gastroesophageal reflux disease, especially if it is Sjogren's is associated with ILD or those who progress. Usually, in the various pictures, according to this study, the median age at lung biopsy was about 62 years. 22% patients were smokers, and it was noticed that if they had previously used steroids, they did better. If they had UIP or interstitial amyloidosis, they deteriorated faster. Lung disease is classified as moderate or severe depending on their New York Heart Association classification or PFTs. For moderate to severe disease, we start therapy with prednisolone 0.5 to 1 milligrams per kilograms, and mycophenolate or azathioprine can be followed long term. Second-line therapy is rituximab, and there is increasing use of nintedanib. If the patient's disease is very rapidly progressive, then do consider either infection or lymphoma, and do consider intravenous steroids for these. The last part of the talk is about clinical trials. Of these are usually checked with either patient-reported indices or SDI, which is the Sjogren's Disease Activity Index. Obviously, it's such a varied multi-system disorder that there are 12 different domains, each of which carry 0 to 5 points, and there's a total maximum of 123 points possible. Usually, patients have less than 40. Just a little bit more about this drug. Ribamapide is a drug that seems to slow progression of Sjogren's. As I said, this has been trialed in India and used in Asia, which supports clinical use, initially shown to reduce IL-6 and IL-17 production in Th17 cells in the splenic tissue in mice, and also in vitro, including TNF suppression. It's usually given as 100 milligrams TDS, and over 12 weeks there are various studies that suggest that it does improve symptoms of dry eyes as well as dry mouth, and there is favorable tolerability. Of the positive clinical trials, various combinations of drugs have been tried. So we'll try anyways. There's a few slides on studies. So rituximab has been tried to be used in helping with salivary gland reduction of IgG secreting cells, but it has failed. Other studies show multiple ways of inhibiting B cells have been used. Of these, combination of belimumab and rituximab has been useful, but the others have failed. Lanalunomab has been used, which is a new biologic, with 2 modes of suppressing the B cells. There was no difference in symptoms. This is a study of eprotuzumab, a CD22 targeted humanized monoclonal IgG1 antibody. Oops. This showed that if this was used, some of these trials are used in lupus because lupus and Sjogren's carry some similarity. So if lupus was accompanied with Sjogren's, it seemed to work, but not without. Then these filgotinib, lanraplenib, and tirabrutinib were used against placebo. Filgotinib is a JAK kinase inhibitor that you know of. Lanraplenib is 30 milligrams, was used as a spleen tyrokinase inhibitor. Tirabrutinib was 40 milligrams dose given as a Bruton tyrokinase inhibitor or placebo. Primary and secondary checkpoints included CRP, symptoms, a patient-reported index, and SDIs. There was no significant benefit over placebo. RSLV132 is a first-in-class drug comprising of RNase 1 fused to the Fc portion of immunoglobulin 1. Again, it did not really cause an improvement in the SDI scores. Blocking co-stimulation by using abatacept. This study was actually abandoned due to increased adverse events, even though it did cause some benefit. And then CL13 is a plasma biomarker which is being developed to see if it will help with Sjogren's. So in conclusion, there seems to be improvement in diagnostic criteria. Current treatment has some deficiencies. Severe systemic manifestations need to be recognized early and treated. Some treatments are improving. There are multiple unmet needs and missed opportunities. Further research is ongoing. Thank you.
Thank you, Dr. Tajvur Sabir. Thank you for the time and effort.